So if you guys were around last month for our webinar, we have the privilege of having Dr. Kevin Caridad join us again for another presentation. So Dr. Kevin Caridad is the founder and the CEO of Cognitive Behavior Institute, an outpatient behavioral health practice with multiple locations in Pennsylvania. He's certified in CBT by the Academy of Cognitive Behavioral Therapy, and is an instructor at University of Pittsburgh School of Social Work. Previously a registered nurse, Dr. Caridad received his Bachelor of Science in Nursing and Master of Social Work from University of Pittsburgh before earning his PhD in Counseling Studies from Cabela University in 2014. Kevin is definitely an expert on these topics that he's been presenting on, so we're really excited to have him. Currently, Dr. Caridad serves as the chair of the Southwest Division. So if you're in the Pittsburgh area, Southwest Division, members of NASW, Pennsylvania, you may not know it, but Dr. Caridad is actually your Southwest Division chair. He founded also the Opioid Alliance in 2017. So we're super excited to have you, Kevin, today, and I'll go ahead and pass it over to you.
Thank you, Tyler. Thanks for that. So let's get started. All right, we're going to talk about panic today. And so what is panic? First, it's an exaggerated threat evaluation. As you see these individuals that come and see you, they're very disturbed by them. Oftentimes they think there's something medically wrong with them. They have this sense of helplessness or powerlessness, that there's nothing that can be done, because oftentimes there's no medical foundation for it, and they feel like it must be something. It can't be anxiety. And typically these individuals have such an exaggerated fear response that they can't process the situation, what they're actually experiencing. Think about a car coming at you. It's not like you can be able to say, oh, let's look at the flowers and the trees to the side. You're focused on what's in front of you. So the same way when you're having a panic attack, when someone's having a panic attack, you really don't have the ability to process kind of that ancillary information that would kind of let them know that this is not really much of a medical threat, or a threat of you going to lose your mind as you think. So they have impaired cognition with that. So some of these slides, including this one, was provided by Spira. Thank you for that. And so basically we talk about panic attacks and panic symptoms and how they are frightening, disruptive, and debilitating. And depending on the part of the body, people can have different symptoms. And this will be on the checklist for the PDSS, as well as the criteria for the DSM that we'll talk about very shortly. So typically for the chest, the cardiovascular, you'll have people with a pounding heart, the palpitations, they feel like they're tight, the chest is getting tight. Oftentimes people feel nauseous or queasy in their stomach. They begin to sweat or tremble, and really what that is their endocrine system really responding. It's that epinephrine, that adrenaline in their body. People can get numbness and tingling in the tips of their fingers and their feet, and the tip of their tongue or on their head. Oftentimes they feel like they're choking, like there's this restriction, and often they also feel faint or dizzy, and some people have passed out. And the interesting thing is, many times when clients come to see me, they think when they pass out, they die. So when someone says pass out with these clients, one of the beginning things I ask them is, what does that mean to them? What do you think happened about what passing out is? So I think that's important to take note. With regard to, the clinical and financial impact of panic is that these individuals wind up in the ER. And I tell a lot of people, I have lots of friends that are ER docs, and I used to give them a ton of cards to them, refer these individuals to me. And probably about 200 cards were given out through multiple ERs, and not one of these clients ever showed up. It's because they really believe there's something medical in nature going on. And you can imagine the cost from someone showing up with really oftentimes mimicking a heart attack, right? So you have either a CAT scan, you have EKGs, you have blood work. You could have a cardiac cath, you could have an echocardiogram. The thousands of dollars that one spends, both on an individual, these high deductible plans who are our clients, the cost, as well as to the insurer. On average, visits to physicians are 6 to 10 times more a year for these individuals. And for these individuals, comorbidities tend to be a lot higher than other diagnoses. And a quarter of these individuals tend to have substance abuse. So we know that the opioid crisis is a big deal. for many years, and it's escalating. And treating these comorbidities are more likely for these individuals to not have to self-medicate. So it's one of the reasons why, as you can see here, it's so important to treat panic properly. Get stuck here. There we go. As far as panic, its impact on absenteeism. As you can see, panic is in the top 5 of all health conditions impacting absenteeism or one's ability to be present. And so this also could be very impactful on work. I have many individuals that are on disability because of them having such severe panic attacks. They won't leave their house or can't go to work because of the fear of them. Also, U.S. panic comorbidities with chronic conditions. As you see, those that are chronically ill, oftentimes social workers, we are the ones either case managing or doing the psychotherapy, brief therapy, either in a pod-like setting, in an integrative setting, or in an outpatient setting. These individuals typically have panic, and it's going to drive up the costs. And up to 38% of clients referred to outpatient cardiology, as you see, evaluated for chest pain or panic symptoms. So once again, just think of the costs related to these individuals. All right, and so we're going to get into what are panic attacks. So there's 2 types, as expected and unexpected. And expected panic attacks are those associations with specific fears. So these individuals are the ones that show up in my office that have a fear of flying. So recently had an individual that wanted to go to Disney World with their family, but was having a tremendous amount of frequent panic attacks because of the fear of having a panic attack on the plane. Or I have individuals that feel like if they get contact with germs, they're gonna have, if they get sick, they're gonna have panic attacks. Or blood, when they get their blood drawn, they will have a panic attack, or they get predisposed to this. So it's specific situations. Or one time I had a first responder began having panic attacks at work because one time they had one and then feared it repeatedly. And so then began to avoid work. It's very specific. So unexpected panic attacks are those that apparent triggers that come out of nowhere. They're not really sure where they're from. And these can be very frightening to individuals because, like with most anxieties, uncertainty is really difficult to kind of manage. And so when they come out of nowhere, these particular severe symptoms, it can really make a client have a real difficult time. And so basically, from the DSM perspective, panic attacks are characterized by 4 of the following symptoms. So the symptoms are rapid pounding heartbeat, palpitations, sweating, trembling or shaking, and that's really that adrenaline rush that's coming, that's creating that. People feel breathless, feeling of that choking. It's really their muscles in their neck tightening up. Chest pain or discomfort, nausea, this is a GI symptom, dizziness and fainting, feeling that sense of unreality, that disassociation that can occur. Numbness or tingling, chills and hot flushes. People can get very cold. Fear of losing control or going crazy, or oftentimes feel like people are going to die, that impending doom. And so we have panic attacks, and then we have panic disorder. So panic disorder are attacks that are reoccurrent or unexpected. Typically, there's at least one attack, and then followed by the person fearing they're going to have more attacks. They don't necessarily have to have them, but they have a tremendous amount of anxiety, fearing that another one will happen. And they also begin to have behavioral changes. They avoid situations. So these are the agoraphobic individuals that do not leave a house, that won't go driving. Maybe sometimes it's over a bridge or a particular highway, or will avoid going to Disney World, these kind of things. So they begin to change their behavior. So one of the things to consider within that is that in order for it to be panic disorder, it's not exclusionary, meaning there's no other reason for this individual having a panic attack, like the physiological effects of a substance, like cocaine, crack, or caffeine, right? So part of your assessment is going to be what is their drug and substance use, what other medications could it be on, ADHD medications or stimulants. You want to make sure it's not a side effect of that, or medical conditions, like a hyperthyroid or an adrenal tumor. These things will kind of really get the heart rate and cardiovascular system going, and people can recognize it incorrectly and kind of really exacerbate panic. And also, this is not explained by anything else, as we talked about. One of the things I use as a standard for treating and recognizing panic disorder is the PDSS, which is a severity scale, and it quantifies and supports assessment for the diagnosis of panic attacks and panic disorder. So it has specific questions it asks and it quantifies them. And so this is going to be important to help validate your diagnosis and your documentation, particularly if there was an audit from a commercial insurance. But also it'll help you make determinations of what type of referrals you're going to make, which we'll talk about, whether it be psychotherapy, whether it be medication, or free Spira, which is a new technology, behavioral feedback technology that's out. And so, basically, when you do this PDSS and you're doing a biopsychosocial assessment, what are you looking for? You're looking for how many symptoms do these people have? How often do they have these symptoms? Are there behavioral changes because of these symptoms? And are there lingering fears of having panic attacks? So this is kind of your gold standard for measuring is panic occurring.
Kevin, I'll also add, I think you sent me that PDSS PDF of that, and that is included in the handout section. So everyone attending should have access to download that in the handout section of the control panel, along with the slides.
Thank you. So when it comes to the treatment options for panic disorder, we're going to spend most of our time on psychotherapy models and approaches, which is CBT exposure, psychoeducation, and actually demonstrating skills. There's medication management, which I'll talk about briefly, and free Spira, a little bit more in depth than the medication management. So when it comes to the medication treatment of it, typically you're going to make that referral to the primary care doctor or a psychiatric prescriber, and sometimes specialists do that, like cardiologists. And so the standards tend to be antidepressants. These are the SSRIs, SNRIs, those kind of things. Benzodiazepines are used, but they should be used sparingly, and they should only be used briefly for a week or two. They shouldn't be used for long-term treatments. We're going to talk about safety behaviors here in the near future, and I would consider, based on what I understand the literature to be, that benzodiazepines is considered a safety behavior. Beta blockers can be used, and these often are used for panic attacks that are performance-related, like people with stage fright kind of thing. And really what it does is it doesn't stop the thinking, but it stops that autonomic nervous system response. So beta blockers are, as I would say, is that couch potato effect of a medication. It slows down the heart rate, brings down the blood pressure, and so brings down the respiratory rate. So the physiological symptoms, which makes people typically be able to manage their thoughts a little bit better. So addressing key physiological components of panic. So what happens, we're going to get into free Spira now. This is a biofeedback technology that's been shown with several studies now to be efficacious in improving panic symptoms and panic attacks. So much so that recently Highmark has completed their own study, which I think was on the news this past week, and it is now covering this. What I will say, the caveat, depending upon the client's deductible, their co-insurance, and things of that nature, but the insurance is covering it. They're the only insurance. There's also a cash pay for these individuals also if they do meet criteria, or if they just want to use it. So typically people that panic from this, at least from free Spira's perspective, is they chronically hyperventilate. And so when they're having a panic attack, there's an alteration in their breathing, even not necessarily visible, but it's shallow, it's more rapid. And over time, when you hyperventilate, even on a lower level, you begin to have physiological symptoms. And I hyperventilate with my clients in a really strong way, and I produce these symptoms myself. And all the symptoms that we listed from the DSM earlier, you will see you could produce with hyperventilation. So what these individuals do is their chronic breathing pattern that is not very healthy for them, or I should say that creates an environment for panic, is what creates the physiological environment for it to occur. I give the example of my kid, my son Andrew last year. He had a science project when he was in 4th grade, and he had to 3 pieces of bread. We had to put one that was plain in a Ziploc bag, one with butter, and one with water. We put 3 of them in the sun and then 3 in the refrigerator. And we looked at which one would grow mold the most. And it was the wet one out in the sun that created mold. It was that environment that created that growth, the environment that was conducive for mold to grow. And the same thing with chronic hyperventilation, even at lower levels, creates an environment that is very conducive for panic disorder. So that's where free Spira goes and tries to really be impactful with biofeedback, train somebody to breathe differently. And so they begin to experience things differently because now it's almost this environment is not there to be to allow that symptom to occur, which is all the ones listed earlier. And what FreeSpire is, it's a 4-week treatment. It trains the client to how to breathe differently, and it's over 4 weeks. So I think initially it's 13 breaths, and then each week you go down 3 breaths. And it really helps regulate the client. And if you can see that little FreeSpire picture on the left, it'll measure CO2 levels with the nasal cannula and also respiratory rate. And that's where the client really focuses on, getting the respiratory rate to be able to be steady, and that allows the normalization of the CO2, which then that environment for the panic goes away and then symptoms improve. I've had clients that have this that have no other treatment other than FreeSpire and have been that improved. I have other ones that, and for that one particular client, they drove 3 hours for FreeSpire to come see me because no one else was doing it at the time. This was 2 years ago. And they came, they drove, they got the initial assessment, they met criteria, ordered the FreeSpire, they came and were trained, went home. A month later, they called me, all their symptoms were away. I'm not saying everything will be that dramatic, but the literature does support here that 83% tend to adhere to the treatment, 85% are panic-free immediately post-treatment, 82% are panic-free 12 months post-treatment, 94% are clinically significant reduction in panic symptoms 12 months out. So it's sustaining, as you can see. And some of the other benefits to the client is that their overall medical costs are improved, less ER visits, and tend to use less medications, which would decrease likelihood of a side effect of another medication. So this is FreeSpire, and something to think about with your clients. And all you need to do is my contacts at the end. If you have any more interest about FreeSpire, I can connect you with the individual. Okay, so now we're going to look at panic and anxiety issues. So what these individuals do is over-exaggerate vulnerability, so they're really hypersensitive to the fact that something bad's going to happen. They underestimate their ability to handle it. They feel like they're not strong enough, and uncertainty is just very difficult. And they get stuck in this association of physiology with those symptoms they're feeling and the meaning of it. So they really distort their cognition. And they tend to develop unhealthy coping strategies, these self-safety behaviors. And safety behaviors are the things that individuals do in order to make themselves feel better, not to have symptoms. But there's a large body of research that show the more someone uses safety behaviors, the more likely symptoms will increase or be sustained. We have to identify those safety behaviors, pull them away over time. So from a CBT perspective, case conceptualization, what this is really doing is looking at a client when they come in, is really what are the things that have occurred from birth to the present when they're seeing you that has really impacted this sense of vulnerability. Let's see if we can identify any beliefs of like, I can't handle this, I'm vulnerable, this kind of thing. And you really want to then begin to make the connections to these beliefs impact your automatic thoughts in the moment. So if I am vulnerable, I can't handle this, is when they have those symptoms, the first thought is I'm going to die, or I'm going to lose my mind. So it's very important to begin to restructure those thoughts and begin to have the client see them in a different way. What I'll say is that CBT, at least from the thought cognitive restructuring perspective, is very needed and is a foundation for treatment. But oftentimes, when it's moderate to severe, it's not enough, and that's why exposures are needed. So core strategies, you're going to identify these safety behaviors, whether they avoid going somewhere, whether they do a ritual, whether they call a friend, they do music, they do something to make themselves feel better, take a benzodiazepine as needed, this kind of thing. Restructuring cognitions and exposures are the core strategies and should be a part of treatment planning. And so I'm going to briefly go over some sessions. So beginning sessions 1 and 2, what you're going to do is that biopsychosocial assessment of your client on day 1. In order to make the diagnosis, you have to know the whole part of every aspect of your client: economic, social, medical history, medication, life events, as well as adding those psychometric scores like the PDSS, specific for panic disorder. It will help you identify the symptoms and severity of the symptoms. You also want to assess the client's stage of change. Where are they as far as their motivation for what they want to do? Some clients will come in day 1 and they will do the restructuring. They will do FreeSpire, they will do the referral, but they will not do the exposure. It can be very frightening because you're asking them to do something they've been avoiding so much. So really understanding where the client is important, because otherwise you leave them at high risk for disengaging from treatment. And so that's why stages of change in motivational interviewing is so important. And then you also want to create a treatment plan for the client, which is including the psychoeducation of the client. And that psychoeducation is explaining to the client the fear response. So when we have fear, if you think of a bell curve, is that it rises up, it peaks and comes down. Really what safety behavior is, what happens is it goes up and then it stays up because you never let your body truly deal with the threat because you're trying to relieve yourself. And so when you have individuals actually sit and accept an emotion, thought, or feeling with regard to panic, and you get them to do it for 1 minute, 2 minutes, 3 minutes, they will come and learn that when they stop avoiding and they sit with it, the body will self-adjust and reset the intensity of physiological response to the situation. And you begin to rehabituate. You get to retrain them and how to look at that threat. Oftentimes, if I have time at the end of the first biopsychosocial assessment, I'll ask a client, and I'll actually say to them, what would you think? I hear you saying that you really felt out of control the whole time about your panic disorder. What would you think if we could do it on purpose within like 10 seconds? I either get the look of death, like this guy's out of his mind, I'm never going to talk to him again, or they look very curious, and I validate that they must think I'm crazy at this moment, or that they'd like to slap me if I joke with them. But I tell them would it seem less random if we could do it on purpose? I'm like, what happens if we just breathe rapidly for 5 to 10 seconds? And when those that are willing and try it, oftentimes the first session, we can see that we can reduce those symptoms mildly just by really quick super hyperventilation, and to begin to see, wow, this guy may know what he's talking about, that there's something here. And you begin to build confidence in the therapeutic clients is one of the ways I've done is by doing that. So you want to give psychoeducation on what panic disorder is, the criteria for which you've assessed them, the number of symptoms they have, why do they meet criteria for either panic attacks or panic disorder, the treatment options that are out there, which is psychotherapy, medication management, or the free Spira, and then what should we be expected in the future sessions. Part of the second session of psychoeducation is explaining the CBT model. What are core beliefs? What are automatic thoughts? What are emotions? What are behaviors? In relation to those beliefs, how do those beliefs impact the automatic thoughts? How those thoughts impact the emotions, and how those emotions impact the behaviors, typically avoidance or safety behaviors. And then what belief challenging is. And then begin to shape and give them tools like thought records to be able to go after those automatic thoughts, how to go after those negative core beliefs, and then making that connection and being mindful of those physiological symptoms. You want to also explain what exposures are, and you want to be delicate with this because depending on how severe the symptoms are, clients may not be so receptive or accepting. So you want to be careful and know your client and how you begin to tell them. What exposures are is really identifying the symptoms you have, how they're not helpful, and begin to retrain your brain in how it experiences those symptoms. And really what we're trying to prove to the clients is that those physiological symptoms are not a threat of losing their mind, going crazy, or death, rather than an exaggerated thought response to an exaggerated physiological response. And by repeatedly going and experiencing those thoughts in a controlled setting here in session and then outside of session, that they will come to see that it is not something to fear. You also want to explain what a sub-score is. For those that you don't know what a sub-score is, it's just a fancy word for saying how intense is your anxiety symptom. And it's you can use a scale of 0 to 10, 0 to 100. I use them interchangeably, but you just want to have a standard. 10 being the highest level, or 100 being the highest level of intensity, 0 being the least. So you want to explain what a SUDS is, that when you do exposures of any type, you want to know what level of discomfort they feel. Because you also want to explain where is the red line as I identify. Where is your line in the sand that we can walk up this ladder of discomfort, but when we go beyond it, it's too much. So if let's say, for argument's sake, some people say a 3, some people say an 8, it'll be higher than you expect. So whatever that red line in the sand is for a SUDS, that's where you want to get the client to go up to and stay. If they ever go above that, you want to use those other key interventions like challenging thoughts, mindfulness training prior to doing exposures. Mindfulness is also important. So using things like breathing techniques, progressive muscle relaxation, how to be present, these kind of things, so that if they ever get over that red line, you can bring them back. So they have those tools. So what we're looking to do is build their sense of self-efficacy while doing these exposures. And why do we do it? I explained the physiological bell curve earlier. And what we want them to do is to be able to stay up there and find out that their physiology will reset on their own, that they do have that ability, and they're not so vulnerable as they think they are, or not so much in control. All right, once you move beyond session 2 into session 3 and beyond, you're really doing the cognitive restructuring, and you're doing this exposures following a hierarchy. And really what you're doing in a hierarchy is building as many situations that they define create anxiety. So let's just say it's someone with agoraphobia, and I've had someone like this. So they would not be able to get off the first floor of their house. So they were always generally at a 3. If they went upstairs, it would be a 5 when I first started seeing them. If they went outside the house, it would be a 7. If they walked off their property, it would be a 10. So as you can see, I already have a little bit of a set of a ladder of a hierarchy to expose her. So what I did was I asked her, how many steps can we go up? Because her red line in the sand was a 6. So how many steps would we have to go up in order to get to the second floor? And so I figured the number was, but let's say it was 4. She would walk to the 4th stairs, she would sit down, and we would wait. And I would say, tell me when that cuts in half. When that 6 would go down to a 3, we'd go up the next step. And I would say, where are you on a scale of 0 to 10? As long as she was under that 6, I would ask her to go up to the next step. And when she got to 6, she would stop and sit, and we would let it reset. So that's one example of how we do a hierarchy, how you can do it in the moment and adapt it in the client, where we had upper floor, lower floor, different levels, but we had steps between that we could use to gauge as we moved along. And so for the client, she found that very helpful. And currently, it's been slow moving, but now she drives 15 miles from her house. And the goal is for her to actually come see me in the office. We do all this via live video. She puts me on her smartphone in a cup in her car. So that's just one nice example of using technology as well as exposure to really help someone improve their function. And so you do this over time. So this is a client that is really severe, has a co-occurring medical problem that actually makes it difficult for her to do some of the exposures. So we haven't moved along. But many times clients move pretty quickly through this, and you can do pretty well in about 6 to 10 sessions with them and get them functioning again. But it's just knowing your client, the situation, building that hierarchy, and then moving them through it on a regular basis. And it's not just doing it during your session. You have to give action plans. These individuals have to go home, or if they're at home, do these on a regular basis. And you want to ask the clients, when you give them an action plan, how likely are you to do this on a scale of 0 to 10? If they say anything less than a 9, you have to adapt it more and you say, well, what do we have to do to change it to get it to 90% or higher? Because they're not going to do it if it's lower. So part of that feedback loop is very important. And so just with very broad strokes here, looking to the finish lines, you're typically doing the PDSS weekly so that you can watch how are they responding to the treatment over time. You want to have that quantifying data to support what you're doing isn't working, right? Because if you just start off with cognitive therapy and nothing is doing, you really want to have that conversation. Is there something else that we should be doing here? Should we be doing medication management? Should you be doing Spira? Initially, you thought you didn't want to do, you just wanted to do therapy. Medications alone typically is typically when medications are withdrawn, they can exacerbate again. Oftentimes, I think when you build that sense of self-efficacy without medication, it's great. But I think a combination of all 3 interventions, CBT along with medication and Spira, will get the best results, the quickest, and probably have the long-lasting results. So, typically structure of a session. So when someone comes in, I do a mood check. There's different ways of going about this. It's just, hey, how are you doing on a scale of 0 to 10 since I saw you last week? And just kind of looking for a dramatic change from prior. The other check you can do is using the PDSS when they come in. One of the other things I use in my practice is called OpenFit. OpenFit looks at 2 aspects of the session. It looks at the outcomes rating scale, and the outcomes rating scale basically is how the client's doing. It actually graphs it for you. It aggregates the data for you. It's very pretty. It's very good for reviewing with clients to show them that they're doing better, even when they don't feel like they're doing better. And at the end of the session, we give something called an SRS, a sessions rating scale. So what this measures is therapeutic reliance. The degree to which your client feels respected, that they felt heard, you worked on things they wanted to, the goals that they wanted to work on, and overall how the session was for them. And those two tend to correlate with clients' outcomes being improved. Because if something is off on either one of them, it should trigger a conversation between the clinician to clarify what's going on so that you can adapt the treatment to that. And that has been shown to be helpful. So there's many different ways. I use the PDSS, ORS, and SRS, but mood check is another way that's a standard. When they come in, you want to review the prior action plan. What did they take home and do? What was helpful about it? What wasn't helpful? What could be more helpful? What wasn't helpful, maybe remove or adapt. What was helpful, you try to enhance. Then you add agenda items identified for the current session. So is it thought restructuring? Is it exposures? And then doing those during the session. Is it asking if they're on medications? Have there been any side effects? Have they had their appointment with the prescriber you referred to? For the other thing is if they're on Spira, have they been doing it like they're supposed to? Which is basically the system. I don't know if I mentioned it. It's 17 minutes twice a day, 8 hours apart. And someone, if they score on the PDS score 10 or higher, they'll meet criteria for high mark to pay for it. And sometimes with the Spira, something you have to be aware of. If they have an upper respiratory infection, it may be difficult if they have trouble with breathing. It'll just delay it a few days, but just something to be aware of. So you want to review, have they been doing what the action plan that you both agreed upon? Has it been helpful, not helpful, adapting and incorporating into the current identified agenda items like exposure, thought structuring, or any mishaps with Spira? Then we want to review constantly because there's lots of literature for therapeutic alliance that reviewing, getting feedback from your clients about what's helpful, what has occurred during a session, what are the key points to take away is going to improve their ability to get better outcomes. And then set the new action plan or homework and review it again, and then send them on their way. So session one, really quick again. You do your assessment, review findings with the client, explain diagnosis, and discuss treatment options. With regard to educate and explain, a little bit more detail, what is an automatic thought? Many of you, I suppose, you learn in graduate school and training post. Some of these automatic thoughts, as you see here, you want to explain what safety behaviors are and why you need to take them away. You want to get a list of safety behaviors. And I also like to rate the safety behaviors on a scale of 0 to 10 on how helpful they are. Because sometimes you cannot, the client will not be able to do an exposure unless they have safety behaviors. So as long as we get traction with the exposure, then I'll begin to pull the safety behaviors out. And I start with the ones that are least helpful and then take the most helpful out the last while they're doing the exposure. So that's why I like to rate them also, so that helps guide me in how I deal with them. You also want to explain the physiology of panic, the symptoms that are in the DSM, and also on the PDSS themselves. You can have the individuals identify there and you document it. You want to talk about the areas in brain response to those thoughts, as well as physiological response to the brain, explain the bell curve about autonomic arousal, about their anxiety going up and why staying there is so important, and that's what exposures hit. And then for Spira, go through the process with them. There's a video on the tablet that you get that will explain it to them, and then you show them how to administer it. It's very simple to do, and it's a nice adjunct to add to your clients, another intervention that you can add to them. But we'll talk more about if we have questions. Please hold questions at the end. Section 3, you want to create that hierarchy of exposures, identify symptoms that they experience, identify what symptoms are most impactful. I talked about the one client, first floor was the lowest anxiety. They were always at a 3. The second floor was much higher, leaving the house, it went up, it went higher. And so it begins to happen when these individuals are exposed to these higher level of anxiety. So the things that used to be an 8 tend to come down in symptoms. So when they're successful, let's say they have exposure at 3 or an 8, and they stay at the 6, and they're successful with that, and that 6 no longer is a 6, it only goes up to a 3, that 8 usually begins to come down to a 6. And so that 8 is now under that red line to do the exposure. So that person was able to go on a second floor. And then once that person on the second floor was at a 3 and cut in half, then we were able to start going outside the house. And then once that cut in half again, then we were able to get in the car and begin to move away from the house. So that's why you want to write a list of hierarchies and identify that red line. So performing exposures, how do you do exposure? So it's really dependent upon what the client's symptoms are. So oftentimes chest tightness, one of the unique ways that I've learned how to do it is using coffee straws. And you can hear my New York accent now for those from Western PA. So coffee straws, they tend to be very small. So I tend to have a box. And what I do is we ask the person to put the straw in their mouth, just seal up their nose and their lips around the straw, and breathe in back and forth rapidly. The more rapid you breathe through a straw, the more difficult it is. Rather than doing slow, deep breaths with the straw, it's much easier. If it's too difficult for them to do that, you could add multiple coffee straws, up to as many as you need. And then what you do is, as they build up tolerance, you pull out a straw. Always, so if it's chest tightness, is how much anxiety do they feel when they experience that chest tightness? So you would do that exposure with the coffee straw, but maybe just breathing once and then getting a feel for it and say, hey, on a scale of 0 to 10, how is that? And then work up in the duration, the number of seconds they spend breathing through that straw. You want to get that up as far as you can so that they begin to change their view of what that chest tightness means. Some of the other symptoms they get, like the GI symptoms, the nausea, the dizziness. Oftentimes what I'll do is I'll have my desk chair, and just like I learned as a kid, you get dizzy when you spin in them. So I'll literally spin my clients in the chair or have them in a safe place and spin themselves. You want to have a big enough office that they can do that and rotate, but you want them to be able to spin more and more so to elicit that dizziness. It's very uncomfortable. So you just start with maybe a quarter spin, then a half a spin, then a full spin, and then third, fourth, fifth spin, and then you can add speed to that spinning. And you want them to be able to tolerate it. You want people to be able to shake their head back and forth. That oftentimes can do that, not too fast. You don't want them to have any head injuries. And with all these, you want to make sure that they don't have pre-existing cardiovascular pulmonary issues or some type of musculoskeletal issue that will prevent them from this. So you can always have a conversation with their primary care doctor about, this is the kind of exposures we're going to do. Are they cleared for it? So you'll be able to document it and be defensive as far as any litigation that you've done your due diligence to make sure they're medically clear to do what you want. And then also you're adding that piece of integration, which is shown also to be helpful to be in contact with the primary care doctor. The other symptoms that can come up with that sense of losing your mind, fuzziness, passing out, even chest tightness is hyperventilation. And so people can hyperventilate like with pursed lips, like you're blowing out a candle, or keeping your jaw open very largely and taking really rapid breaths. That's the most intense. Doing it like that will produce symptoms fairly quickly. So within 10 to 15 seconds, symptoms will tend to come on. And what can happen is there's typically just a 3-second delay of when you stop hyperventilation, it'll get a little bit more severe, the physiological response, and then it will plateau and begin to come down. And so you want to do that with clients also. Ease into it. What I would say, if you don't have panic attacks yourself, is go and try these things while sitting on a bed, so you don't fall over or get in a chair with arms, so that you get used to it. And so you will find that clients over time really do get better with these. I do this day in and day out, and it's a really good method. So I use coffee straws, I'll use spinning in a chair, hyperventilation, and if it's people feeling like they're suffocated or very hot, I'll ask to put on layers of clothes and winter clothes. Sometimes, depending on their fitness, I'll make them do burpees in my session or run up and down the stairs and then come back and hyperventilate. We can do cycles of it. I think I'm going to give you the general feeling of how to approach panic, but I do suggest further education and also supervision or consultation with this. So when you have clients, you have someone to talk to. I think that'll be important, and we can talk about that later. Okay, talk about exposure. So session 4 and beyond, it's just what you're doing is you're repeating exposures, you're processing that with the clients, their thoughts about the exposures, the meaning of that physiology and their emotions, and showing them over time that you haven't died. Or if you've passed out, what's the big deal? I have a client that passes out, so I make her sit in the middle of a queen bed and she hyperventilates. I say, if you pass out, you pass out. If you're in my chair, they said, what are you going to do? I said, I'll say hello when you come to. So, and I've cleared that they don't have any medical problems prior to, but no one has ever passed out. So when we take that fear away of passing out and they're just accepting and bringing on these symptoms, interestingly enough, I've never had a patient pass out even when they have a history of passing out. So it's such a validation for the clients over time to build that confidence up. Really what we're doing is, by this repetition, we're proving the client's self-efficacy, their belief that their ability to tolerate the uncertainty, their ability to have that resiliency to be able to sustain those symptoms, and that it's not going to do what their worst fear is. And then over time, as that PDS comes down, is you want to begin to decrease your visit frequency. You want the client not to be dependent upon us. You want them to be as independent as possible. So I begin to wean the clients out. Sometimes I would start weeding them out by session 3 or 4. Sometimes it's not till session 8. So it's dependent upon the PDSS, and it's really from client to client. You want to make sure all the client goals that you have, like the client I was talking about earlier, who wanted to leave the house, her goal was to be able to drive to her initial goals were to be able to drive to her child's school. She hasn't been there for a year to visit her mother, all who are within 10 to 15 miles, and she's now doing that. The new goal is for her to get to my office and to be able to go and travel wherever she likes. And so we want to make sure we reevaluate when she hits certain goals or any more goals. Because clearly, even though someone's moving 10 miles from their house, 15 miles from their house, when they're already is a major milestone when they couldn't leave the house, but there's much more functioning she could get. And so we continue on. And once all goals are met, and then the PDSS has basically 0, you have to start thinking about discharge. So part of what you're doing, right, with the clients during your assessment is looking at the immediate fear response. When they have that fear response, what is their reappraisal of it? So what's their worst case? What's the cognition? I'm going to die. Something is not going to go well here. How is it impacting their functioning? How are those behaviors keeping them from doing things? And oftentimes logs of anxiety experience. And this brings up somebody who was having a panic attack on planes. They came in because he can't fly anymore because he had a panic attack. I'm like, okay, so let's do this. How many times have you flown? This was a business person, and this business person had flown, I think, 100 times in the last 3 years. So we kind of said, okay, so out of the last 100 times, how many panic attacks have you had? And of course, the answer was 1 time. So he's traveled all this time. So out of 100 flights, 1 panic attack, he's been having a miserable time of work because of this fear. And it began to give him perspective that it's not as exaggerated. He's experiencing it in an exaggerated way than it truly is. And I'm careful to define with clients when I say hypersensitive or exaggerated, that I'm not minimizing them. And I'm explaining to them ahead of time that linguistics, the words I'm using, is to respond to the cognitions and physiology. What they're experiencing is real, it's very real, but we're using that to define kind of the response so that we understand it. And I haven't had any issues when I do that. And so that's part of the conceptualization with the client. So one of these logs can look like, so what are the triggers? So flying, what's the max fear? So it would be 8. What are the thoughts? I'm not going to be able to get off the plane. I'm going to go crazy. They're going to arrest me and put me in the crazy asylum because I'm not going to be able to be handled. What is he feeling in the body? It's this overwhelming dizziness, shortness of breath, chest pressure. What are the behaviors? He's been making excuses to his boss to go on the plane. Self-evaluation log, right? So what you do is you do this over time. Is once they feel strong with the exposures and they're willing to go out and do the real deal again, get back to life, what they then do is you want them to fill us out. So flight 1, after doing treatment, what occurred? Flight 2, what was it? We know was, so the trigger would be flight. What was the max fear on that flight? And over time, what you should see is, let's say it was an 8, where each flight should start to go down lower and lower. And actually here in Western PA, we have access, someone I know has a plane, I actually take people up into small planes and fly around with them once they're ready, once I've walked up that hierarchy, and explain to them that at some point we're going to make turbulence on purpose. So we really try to ramp up the exposures with their full knowledge and their willingness to do so. One of the things I always outline to a client, I will ask them to do things, I will push them, we will plan this together, but they'll always have to give the okay, and they can always say no at any time. So when you do these goals or these exposures and cognitive instructions, you want to be specific. So what are you doing? You want it to be measurable. So for the person in the house, it was specific distance from the first floor. What was measurable was how many steps in that moment to get to the top of the stairs. Once it was getting out of the house, it was how many feet away from the house. Then we began to how many miles away from the house. It was very measurable. And it was achievable. It was set with the client. So part of it achievable was distance and level of anxiety she experienced during that distance and how many seconds she stayed with that anxiety. We want it to be realistic and relevant. So if it's about getting away from the house, you want to make sure that the exposure is dealing with that. You don't want it to be unrelated to that. So you want it to be realistic that the client can be able to achieve it, because otherwise you're just going to reinforce their perception of inability, and you want to make it relevant to the situation. And you want it time limited. So you want to structure it. We're going to do this specific task of getting away from the house for this number of feet, for this number of minutes. We know it's achievable because we know what we've done prior, and this is just a little bit more than it was prior. It's realistic because we know this is something that we've tested out, and it's time limited. So the client knows how long they're going to have to sit with the discomfort until they can reset. So it improves their ability to overall handle the exposure. And the main objectives for the anxieties is to reevaluate their cognitive beliefs, to really shift them again, to shift their threat focus, normalize the fear and anxiety, strengthen self-efficacy, and develop adaptive approach to safety. You want to pull those away. That's our objective. Restructuring we dealt with. You can do that cost-benefit analysis. So with this individual, what's the long-term consequences? I'm not seeing my family member who's in a skilled nursing facility. I'm missing out on sports and school events with my child. The impact of thinking is low mood and high anxiety levels, and the cost-benefit analysis, it's just not helpful to their life. And so because of that, they're very much, you go through this, and it's part of that motivational factor to get them through those stages of change to do what you guys decide would be the best. And so the cognitive restructuring experiments is that negative prediction, right? So what do you think is going to happen when you go up that stairs to the second floor? That my anxiety is going to go up and I'm not going to be able to handle it. And so so let's be specific. If you go up 4 stairs and you sit there, what do you think is going to happen? I'm going to lose my mind, right? And so what are you going to do if it gets that bad? I have these built-in mindfulness techniques. I'm going to restructure my thoughts. So what happens if it goes that way? Well, we have 2 ways of going about this exposure. Not everything's going to go well. So 1, we either have to tolerate a negative outcome, or 2, maybe realize most of the time there won't be a negative outcome. And so the implications when the person did this experiment was, yes, her anxiety did go up when she went to the 4th step. But when she stopped and when she turned around and paused and waited, after about a minute, her anxiety decreased and she was able to take on more. So the implications of that specific experiment is she can tolerate it. Actually, when she does more, she'll be able to do more and improve functioning, even though she may maintain the same level of anxiety. For her, that was empowering. For many clients, it is. Coping strategies, we talked about mindfulness, the different ways about that. We talked about that log with the triggers and following that through. And then specific tips, depending upon the uniqueness of that client, which you want to incorporate that will basically decrease safety behaviors, improve adherence to exposures, and restructure thoughts that are not accurate. So different ways of doing exposures. Oftentimes you can do it in that hierarchy. So depending upon the client. So in the client, she wasn't actually in my office. It was always virtual. So we were using her real environment the whole time for her to actually do it. At first, she wasn't even thinking about possible to go up the steps. So what we did is, as she sat on the first floor, was imaginal. So what would it be like to walk up the first stairs? What level of anxiety did you experience? And so what she would do is, by going in her mind, although not actually doing it, for her, it was intense, but not as intense as actually doing it. So we were able to do the exposure without actually doing it by using imaginal, having to walk through her mind, using her mind and walking through it before actually doing it. And then doing that over and over again, like we talked about earlier, that when she gets to a 6, she's to stay there in her mind until it cuts in half and then walk up. And sometimes with some exposures, not particularly this client, is maybe you just spend the whole time on that 4th step. And so maybe it doesn't cut in half, but it goes down by 1 or it goes down by 2, and that's okay. It's still gain. As long as you're moving, you want to continue to move. The other one is actually doing the physiological symptoms that we talked about earlier, which is breathing through the coffee straw, spinning them, making them do burpees, loading them up with clothes in the middle of the summer, or hyperventilating. These are the strategies that oftentimes are needed also because you want to help restructure them by actually doing the exposures, but sometimes, depending on the client, some will prefer or will get better results by experiencing the physiology not in the event. So they're sitting in their account, on their couch on the first floor, experiencing all the symptoms by all these breathing through straws, hyperventilating. So then when she actually gets to doing the real exposure, going up the steps, she recognizes those symptoms as not being a threat as she once did. And so that can be helpful by doing that first. So we have limited time, and I want to leave something for questions. So I had the one. So Tyler, why don't we get a feedback? What would be helpful right now with regard to with the remaining minutes? Is there any questions that I can spend time on or review with something to be more helpful?
We do have a few questions if you want to just kind of take those. Since we just got some minutes here, let's see. So one question I thought was particularly interesting, is it necessary that these sessions be in person? And it sounds like some of your stuff includes, like doing a video conferencing and that kind of thing remotely. So can you talk more about that?
Yeah, so no, it does not have to be in person. And a lot of the things that the client is going to do once you teach them how to do this and they feel confident about doing, the technique you want them to do and feel confident that they're able to complete it, you send them on their own to do it outside the office. And so that's something that they will do, or you can use video technology for that. So we do that all the time. So yeah, you definitely can do that. You don't have to be with the client.
Very cool, yeah. Let's see here, we have another one. So have you found that ER doctors, the reason I ask is I know you are also part of our clinical care committee who's doing the integrated behavioral healthcare thing. So this kind of speaks to that. Have you found that ER doctors are often uncomfortable and lack the knowledge to treat a patient who has panic symptoms? Do they misdiagnose it and that kind of thing?
Well, I think there's a medical legal perspective. So I think ER doctors are going to treat it and rule it out. So they're probably going to do the lab work and EKGs. Someone coming in, even if it was for the 5th time, they will never not address it potentially being a cardiac event. But they do recognize that it's once everything is negative, which they feel the duty they have to, that it's panic, and they do make the referrals. I think it's just, I'll reiterate, clients just believe it's medically in nature and will not show up oftentimes from the ER at least. Mm-hmm. More likely from a.
Yeah, that makes sense. So how do you manage someone who maybe can intellectually wrap their mind around the fact that they have an anxiety response and that they're safe, but they're still experiencing panic?
So just want to make sure I heard the question. So intellectually they get it, cognitively they get it, but it's still happening.
Yeah, that's what I think is what they're asking.
Sure, and typically many of the clients that are moderate to severe, that's exactly the issue. So the only way, so they may know it's not medically because they've been cleared. They know it's been told, they meet criteria and they understand why, but nevertheless, it doesn't make the symptoms go away because they still have typically safety behaviors. When those symptoms come, they're doing something to make themselves feel better about the symptoms, rather than fully embracing, accepting them that they may come or they may not come, but when they do come, they'll handle it. And when they do come, it's not a threat and that they'll be able to tolerate it. And that's why the exposures are so important. Or referring to psychiatry or the free Spira can really be helpful with those individuals.
Gotcha. Okay, that makes sense too. So another one that's interesting. Any thoughts on working with panic in clients where a true physical limitation is part of the panic? For example, a diabetic fearing having low sugar reaction in public, or a physically disabled person fearing falling. Like those are actual physical fears, but they maybe have panic related to those things.
Sure. So I appreciate that. So medical conditions that are that you'd have to be cardiovascular or pulmonary issues, you want to be clear about both free Spira as well as the psychotherapy part. But having diabetes in and of itself is not going to be something that eliminates it or someone passing out. So I have a client actually that would pass out at the gym. So in order for truly to do the exposure, I said, okay, she knew what the symptoms were going on. So what I would have her do is sit on the ground so if she passed out, she wouldn't be injured, but totally accept and bring on the feelings of panic. And this is a client that did both psychotherapy as well as free Spira. And she stopped passing out. So even if it's diabetes, they may have a real fear of it. But where I begin to do with restructuring is, regardless of having low blood sugar or not, there's medical things that you can do with your medical team to improve that. That said, is once you get the best you can do with that, having anxiety is not going to be beneficial for improving the situation for the diabetes. So how do we handle the anxiety different? Now that we know it's not going to help, it's not going to make it worse, meaning it's not going to help the diabetes. It's only going to make your situation, how to manage it, worse. So let's begin to look at this differently and manage it. And then once again is you restructure their view of how they experience the panic with their chronic health disease. And then also begin for them to habituate, to learn through the exposures and cognitive restructuring that panic is not a threat. So they usually, if you begin to tease out what are their symptoms for hypoglycemia and panic, they're going to be different. And so over time, you have to educate them and then condition them to experience them differently.
Gotcha. And what does the process look like? Somebody asked about like getting a medical report ahead of time. Do you actually request a full medical report, or is it more or less a consulting with the doctor and getting sort of a doctor's note that says that this is an okay treatment?
So I think there's different ways of going about it depending upon your comfort level. So I ask clients to deal with uncertainty, so I do too. So what I'll do is on initial assessment, when everybody comes, we have everybody fill out a consent for treatment so that I can communicate with their medical doctors. And so that's for free communication. And so then I'll reach out to them and say, if there's a concern for medical reasons that I want to clarify, this is what I'm going to be doing. What are your thoughts about it? And if they give me affirmative, it's okay. I'll document. I called primary care doctor, discussed doing exposure treatments, because being mindful of the client's medical diagnoses and listing them. Talk to the medical doctor about these diagnoses in reference to these exposures, which we will be doing. And the doctor said this would not, it would not keep, I'm trying to think of the word here. It would not eliminate, it would not stop you from doing exposures. You're still okay to do exposures despite it. It's not a contraindication with the word. It's not a contraindication for doing exposures. So you could either get a report directly if you wanted, but I think calling or them just saying it's okay, sending a note on what you're going to be doing in your plan for exposures and having them to say it's okay, I think is a good way to go about it. And it'll be sufficient.
Awesome. Yeah. Thank you so much. Yeah, I think it looks like we're just about out of time. So I did post the link to the evaluation if you guys are interested, if you're trying to get out.
So let me just do one quick thing there. So
Okay.
for anybody wants further information, my email is at the end. There's a website, my email is there, and the phone number is there. So for a few things, this stuff can be scary when you're first doing it. If you want supervision, we could do supervision for you. It's at low cost. You can get a group of 8 people. It's like $20 per person per hour. It can be really reasonable, and it's virtual. You don't have to be there. For those that struggle with psychiatry referrals, we do psychiatric referrals virtually. So and you can keep your clients. You don't have to transfer them to us. So the Cognitive Behavioral Institute, if you need a psychiatrist, we get people in between a week to 3 weeks. We're very quick with that. And free Spira, I would suggest calling me about that if you think you have chronic panic disorder, and I can steer you that way. I want to be more helpful. It's very important to me as a board member to add value to your membership for the stewardship of social work, that we support you in economic ways. And so please reach out to me. Let me help you improve in these areas that you want. And if there's any other content related to psychotherapy or integrated behavioral health, what have you, please make the request and I'll develop a program for you for another lunchtime series. Otherwise, thanks for your attention.